Okay, so we're going to be going over cancer and blood problems like hematological problems. So some terminology to understand carcinogens can be anything physical, chemical, or chemical. We're exposed to carcinogens every single day of our lives, but we have things that we're going to talk about that are existing in our bodies that help fight against carcinogens turning into tumors. One important carcinogen to know, as we've talked about many semesters in a row, tobacco or smoking increases the risk for 17 different cancers. And so stopping smoking is one of the best ways to prevent cancer. Some other carcinogens can include red meat, obesity, nitrates, not eating whole grains, fruits, veggies, stuff like that. So proto-oncogenes, whenever you see onco, just think cancer. Proto, I would think of like pro meaning good. So these are normal cell genes that regulate normal cell processes. So these are our good, like anti-cancer cells, basically. Oncogenes are tumor-inducing genes. So starting with onco, cancer, they're mutated proto-oncogenes. Tumor suppressing genes. So tumors are basically cells that are going crazy. They're dividing like crazy, they're growing like crazy. So tumor suppressing genes decrease cell division, they repair DNA or mistakes in the DNA. They tell cells to die, basically. Benign is not cancerous. That's a good thing. Well differentiated, meaning it looks like parent cell. It's easy to tell where it came from. If something's not differentiated, really, that means it's like malignant and it's spread to other places, and it's just cells growing and attacking and taking up the space of what normal cells would have been taking up. Benign, so they're usually encapsulated. It's contained within a capsule. Malignant, cancerous, can be undifferentiated, can't tell origin, or well differentiated as well. So on both ends of the spectrum there. Metastasis moves to other organs than the origin site. So common sites of metastasis are lungs, bone, brain, liver, and adrenal glands. Okay, so different stages of cancer. We have initiation. This is when that initial DNA mutates after exposure to carcinogen. Most of us have cells that have been initiated. So we've had this happen because we've been exposed to so many carcinogens, but we have those tumor suppressing genes that stop it from becoming harmful. The next stage is promotion. This is when you're repeatedly exposed to their carcinogen. So let's say you smoke one cigarette and maybe you had some initiation go on, but now let's say you repeatedly smoke that cigarette. You have repeated exposure to this carcinogen. Um, at this stage, this doesn't mean you're going to get cancer. It it can, but it's still reversible. You can stop smoking or change your lifestyle and reverse that cancer process. That's why it's really important to educate patients on the risks and the benefits of stopping. Progression is when we get that tumor mutation, that mutation that causes a tumor growth. Cancer's growth is basically limitless. They have what's called angiogenesis, angio meaning vessel, genesis meaning birth. So they can make their own blood supply, meaning the body doesn't even have to support this tumor for it to keep growing. Blood contains oxygen and all the nutrients it needs to grow, and tumors make their own. So that means they can make their own energy, and they also have the ability to evade the immune system. They hide from it essentially. Okay, so very sucky, very dangerous. So this is how we classify different tumors. So there's the anatomic model. So this means you look at the tissue of origin, where it started, its anatomic site, and its behavior of the tumor, if it's benign or malignant. So this is using like our prefixes to tell location, the suffix behavior. So things can be like oma, meaning benign, carcinoma, sarcoma means malignant. So there's just a list in your textbook of different like terms under the anatomic classification used to define tumors, and it might be helpful to just look at them so you can get a better understanding of like what this tumor is just based on its name. Then we have histological. This is the appearance and degree of differentiation of the tumor. So again, differentiation, well differentiated, meaning still looks like the parent cell. So we have grades X to 4, X meaning can't be assessed. 1 is well differentiated. The origin in situ, it just means it's at its origin. It hasn't spread anywhere else. 2, there's moderate differentiation, locally invasive. 3, very abnormal looking, poorly differentiated. So you start to not be able to tell what tissue it is. it's spread to lymph nodes. And then 4, it's immature and undifferentiated metastasis. So the worse your cancer is, the more undifferentiated it is, and the farther it spreads. Low grade, we pump chemo for when the cells start to divide. So this is different types of treatment. And then a high grade, so if you get, okay, so sorry, grading, we're talking about X to 4. So a low grade, you pump chemo for when the cell decides to divide. And then high grade, it responds better to chemo because they're more frequently dividing. And so chemo, low grade, it's chemo is like prophylactic when you have a low grade tumor. So it's like, so it doesn't like decide to divide. But chemo works best when you have a higher grade because those cells are constantly dividing. And the way chemo works is it attacks the cells when it's dividing to stop it from dividing by killing off all the factors that cause it to divide. Okay. And then we have just the normal staging. So IS is in situ 0 to 4, which is metastasis. And this is just based on like TNM staging. So tumor size / invasiveness, lymph node involvement, that's where that N comes from. And then M is metastasis. TNM is a pretty common like thing you're going to see. So definitely know that one. And yeah, these are pretty important. Okay, so this is that thing I was talking about. So these are the TNM staging. So like the X, remember, can't be assessed. 0 in like TIS in situ hasn't moved. T1 has invaded the submucosa. Then it goes to the muscularis. Then it goes to the next perirectal tissues. And then it goes to other organs or structures. So we can see how the bigger the number, the more it's metastasized. Same thing if it has lymph node involvement, the higher the number, the more lymph nodes are involved, distant metastasis, and yeah. So sorry, I guess what I meant from up here is the primary tumor. This is talking about like it's spreading more within the local site. So let's say you have colorectal cancer, starts in that very small colon area, and then it's spreading to like the rest of the colorectal area. And then as you move down to the M, it's metastasis to different areas of the body. So this is just how much it's invading the actual spot it started. Sorry about that. Okay. Then we have tumor markers. These are specific to each individual. And so one amount of tumor marker in one individual is going to be different in somebody else. And so the way you can compare, you can't compare one person to another, but you take like their baseline or their first tumor markers you've taken and compare it to the next time for that same individual. So notify provider if tumor markers are elevated for that specific patient based on their baseline. Yeah, and then you can't compare it between people. Some common tumor markers are like for testicular cancer, like HCG. That's why if men take a pregnancy test and it comes up positive, it could mean they have testicular cancer because it's detecting HCG in their urine. Prostate cancer, PSA, breast cancer is not mentioned here, but BRCA or BRCA or the HER right here, breast cancer. Yeah, those are some common ones. Okay, so symptoms and the 7 warning signs of cancer. So basically increasing fatigue, weight loss, unexplained pain, and then use this CAUTION acronym for the 7 warning signs of cancer. So change in bowel and bladder pattern, a sore that doesn't heal. So if in the case of melanoma, maybe unusual bleeding or discharge, thickening or a lump, indigestion, difficulty swallowing, obvious change in a wart or mole, or a nagging cough or hoarseness. Nagging cough or hoarseness is one of the first signs for lung cancer or throat cancer. Okay. Diagnostic tests, you can do a CT scan and a biopsy. Those two are the gold standard. Biopsy is the only way to definitively diagnose cancer because you can see a lump somewhere in a CT scan, but to know if it's cancerous, you have to get a sample of those cells to see if it's benign or malignant. Okay, the PET scan is pretty common with cancer. It uses a radioactive isotope and it can detect metastasis. And an example of that is right here. I'm not a radiologist. I don't know how to read all of these things, but as a nurse, you'll learn and you'll see different diagnostic tests and different screens. And it would be a good idea to ask radiology or a doctor to explain it to you so you can get more familiar with it. So treatment, there's lots of different treatment options. If they're looking for a cure, we're saying this cancer can be completely eradicated. A lot of cancers, though, are only controlled. They're not completely eradicated, but we maintain the status. So it's not growing, but it's also not shrinking and going away. Palliation, so palliative care, we're controlling symptoms. Pain is one of the biggest ones. With cancer, cancer pain is off the charts. And with palliative care, we're trying to maintain the quality of life. Okay. And so if they're having cancer treatments, usually the goal will be control and maybe palliation. Okay. You can do surgery. So there's different types of surgery, and this is important to know. It can be a prevention, so getting like a double mastectomy because breast cancer runs in your family and you tested positive for the BRCA gene and you want to just not risk it. Diagnosis can be biopsy, cure, removal. Again, a mastectomy can be a cure, right? Getting a total mastectomy and removing those lymph nodes to get rid of that breast cancer. Rehabilitation, so they can do breast reconstruction, for example. Supplement surgery would be putting in a feeding tube or a port so they don't have to access a peripheral vein every time they get chemo. And then palliative would be a surgery that's purpose is to decrease pain. Radiation, there's a type of radiation called external beam radiation. There's no risk of radiation exposure to others, so no need to worry there. But then there's brachytherapy, which internal radiation, they plant seeds basically in the body that have radioactivity. Can be an implant that over time releases seeds. It can expose others to radiation. So you want to be really careful on exposure to the patient. Usually people working in cancer centers, I don't know if you've been in the OR and seen them wear like those monitors that monitor how much like radiation they've been exposed to. But the general standard is ALERA, so right here, as low as reasonably achievable. So you don't want to spend like excessive amounts of time with the patient. You want to be careful who visits, definitely no pregnant people or children visiting when they're radioactive. Bathroom or any secretions want to be contained. So like a bathroom specifically for that person who's gotten radiation treatment. And then other things with radiation, the skin gets extremely irritated. So just be teaching them, don't use any harsh soaps, fragrances, make sure to put fragrance-free lotion on, decrease your time in the sun. That's pretty important. And then the other thing with that is, so there's chemo. So it can be single agent or combo. Combo is the most effective because you want to get those dividing cells at different stages of division. I'm not going to go over all the stages of cell division with you, but if you can think there's a couple stages that cells go through to keep dividing, chemo targets that division. And if you get multiple different chemo agents, it targeted at different times and be most effective for killing off cancer. So that's a cell phase specific. So it can like destroy it during metaphase of reproduction, or it can be non-specific and where our purpose is just to like eradicate all the cells in the area. Before they get chemo, you want to treat them with different medications, dexamethasone for itchiness as well as inflammation, Tylenol, and then ondansetron, Zofran, because they get pretty nauseous. Chemo, there is a high risk for extravasation. So this is a very important thing to understand. Chemo can easily like infiltrate and leave the veins and get the tissue around it and basically like destroy the tissue and make it necrotic. Chemo is a vesicant, so it's extremely hard on like hand or like AV veins, or sorry, that's supposed to say AC veins. It's like, what is an AV vein? Anyways, AC veins. And so you want to do somewhere in the forearm, or they'll have a port that's implanted that you access with like a special bent needle. Quickly dividing cells are more susceptible to treatment because you catch them in that dividing stage. You can get IV, PO, intraarterial, intraperitoneal, intravesical bladder, and intrathecal chemo. So different areas to target different types of cancer. You want to take precautions as a nurse. So you want to double glove, use closed systems instead of open. Don't touch any of the secretions. Make sure they're exposed, like destroyed properly. Treat spills quickly, just things like that. Wearing the proper PPE. So if the drug extravasates, I don't even know how to say that, there's extravasation, The procedure is to stop whatever's flowing in immediately, disconnect the IV tube from the cannula, aspirate any drug that you can that's left from the cannula, give an antidote if there is one, and notify the physician. Okay. And that's to save their limb and their muscle surrounding there. Okay. More treatment, there's immunotherapy, so biological therapy, and targeted therapy, so targeting like cell receptors. So, important term to know is the nadir. This is the lowest point of their immune system. It usually occurs around 7 to 10 days after treatment. During this nadir, you don't want them leaving the house because their white blood cell count is low. They're way more susceptible to illness and disease. And it's going to be the time that they're feeling better. So they're going to want to leave the house, want to be social, but you have to educate them to not do that. The vaccines, they have to stay up to date on their vaccines because we don't want them to get infections that could possibly kill them. So a vaccine is given at the nadir because it takes about a week or two for the vaccine to start to be effective. And once that vaccine starts to be effective, their immune system starts to build back up. If you give them the injection at the time of their chemo, the vaccine will start to take effect and like start building immunity at their nadir, which can put them at risk. With immunocompromised individuals, we are never giving them a live vaccine, meaning a vaccine with live properties that can actively cause disease. So that would be like the flu nasal spray. I don't know if you guys have ever gotten them, but I did when I was a kid. Sometimes those would be an absolute contraindication. Another way we can tell how their white blood cells are doing, if they're neutropenic or not, is doing an absolute neutrophil count. That's just taking the percent of neutrophils and the percent of bands, so immature neutrophils, times the total amount of white blood cells divided by 100. And the number you get, if it's less than 500, this is critical. You're not giving them chemo. Their white blood cell is just too low. 500 to 1,000, possibly like hold chemo. 1,000 to 1,500, okay to do chemo. Okay. Neutropenic fever, we've learned about this before, but it's still very important. If they ever get a fever that's close to or 100.4 or over, this is critical. This is the patient you're going to go see first. Okay. You're going to teach patients you're taking your temperature 3 times a day, no matter if you feel great or not. Okay. Just because their white blood cell count is so low, they can go septic real fast. Other treatments, they can get hormone therapy, gene therapy, hematopoietic growth factors, stem cell transplantations. So this is just if they have like bone cancer, they're going to get treatments to treat like their anemia, their blood products that are missing. These have to be HLA matched. So we have like factors in our body like HLAs, and they have to be perfectly matched to avoid rejection. So that's why it's like bone marrow transplants. You can be a donor, a bone marrow donor, or whatever, but they have to be perfectly matched to the individual. There's a lot of complications that can happen with cancer. So one is most common is infection, pancytopenia. So they have low pan, meaning everything, low white blood cells, low red blood cells, and platelets. So there's medications to stimulate bone marrow production, but they cause a lot of pain. So there's a high risk of non-adherence from the patient. So breath sounds are super important when assessing cancer patients because respiratory infections are the most common opportunistic infections that cancer patients get. So listen to those breath sounds. Fatigue is the most universal side effect of cancer and cancer treatments. Cancer pain is a priority. They can become tolerant to narcotics. They have to receive a very, very high amount to get the same effect. So a lot of times you're going to see some absurd amounts of narcotic for this cancer patient because they've become accustomed to that pain relief. But it's still a priority. They shouldn't be in pain. You can get itchy skin and burns, chemo brain, so they're forgetful. So educate, like set a schedule, have a medication planner. They may have altered body image, especially those dealing with breast cancer or testicular cancer. Mucositis, so they have sores in their mouth, and so you're going to rinse with a weak salt and bicarbonate mouth rinse, and you like swish and swallow is what you do with those mouthwashes. You can get lymphedema, so a lot of times this happens when with breast cancer after mastectomy, the lymph nodes can become swollen. So a lot of times you'll see them wearing like the support stockings on their arms for life. Okay, Other complications, cardiac tamponade, which is the sac, the pericardial sac around the heart. And then the heart, the space between that gets filled with fluid and pushes on that heart. You're going to see Beck's triad, which is the symptoms. It's low blood pressure, distension of the jugular veins, and decreased or muffled heart sounds. Okay. Other signs and symptoms, tachycardia, weak pulse, pulsus paradoxus, dyspnea, cough, pain, or the restless, because that cardiac output's not great. The treatment for that is a pericardiocentesis, so using a needle to pull that fluid off, radiation, a sclerosing agent, and steroids for that inflammation. Okay. Spinal cord compression, common in prostate or ovarian cancers because of their location. Signs, back pain, they're weak, motor dysfunction, paresthesia, numbness, or bowel bladder dysfunction. Treatment for that is a laminectomy, so they cut into that, radiation, steroids, and chemo. So basically, like you're just trying to treat the cancer so that side effect goes away. Hypercalcemia, they're confused, lethargic, restless, their EKG changes because calcium affects the heart. Coma, weak renal calculi, so kidney stones, polyuria, or polydipsia. Treat is to hydrate, so you're trying to dilute the amount of calcium in their blood, give Lasix, waste a ton of electrolytes, biphosphonates to get that calcium out of the blood and suck it back into the bones. If you give a biphosphonate, make sure that patient drinks a full glass of water and sits up for 30 minutes. That's just the directions that come with that medication. Steroids, calcitonin is the antagonist to calcium, and then monitor renal function. Okay. Superior vena cava syndrome, the blood flow through the vena cava is slowed down. So there's going to be jugular venous distension or swelling, facial edema, periorbital edema, so that puffiness in the eyes, erythema, so redness, dysphagia, they can't swallow as well, respiratory compromise, intracranial hypertension. And like elevate the head of bed 30 to 45 degrees, avoid straining, so like no Valsalva when they're going to the bathroom. You want to treat the cancer and just get it down with radiation and chemo. This can also happen if they just got a fluid bolus. So like if they just got a ton of fluids and they start to back up towards like their face, that could be why. Another one is DIC. So platelets decrease, they're being used up to clot. And because so many of the platelets are being used to clot in all these places in the body, there's massive hemorrhaging in the body because there's no more platelets to clot the important stuff. So bleeding, shock symptoms, low BP, tachycardia, PT and APTT are changed. So heparin is going to be used to diffuse like the clots, antibiotics, treat for possible sepsis, blood product replacement, probably going to be giving them platelets, and then bleeding precautions. Okay. Septic shock. So again, if they have that fever, it's an emergency. They can go septic real quick. I'm not going to go over treatments for that because we went over that in a different video. But SIADH. So ADH is the hormone that retains sodium and water follows sodium. So both of those are going to be retained, causing fluid volume overload, weight gain, decreased loss of level of consciousness, hypertension, tachycardia, hyponatremia from dilution, nausea, vomiting, concentrated urine. So if you think tying in hemodynamic monitoring with SIADH, their CVP and PAWP are going to be high because they have a lot of fluid on their body. So treatment, EKG monitoring, seizure precautions, because that's sodium imbalance, loop diuretics to get rid of that water. Okay. Tumor lysis, and oh, and they're also going to be on a really strict free water intake, like 500 mils per shift. Okay. Tumor lysis syndrome, when the cells are killed super rapidly, it releases ions and like metabolic byproducts like potassium. Cells hold potassium, so anytime cells break apart, it releases potassium into the blood. This can clog up the kidneys, and it also messes with the electrolyte balance in the body, which, going back to the electrolyte video, we know that can have a huge effect on all of our body systems. So we're going to see hyperkalemia, so EKG changes especially, hyperphosphatemia, hyperuricemia, so uric acid. So we want hydration, kidney monitoring, so monitoring that urine output, Isonos, DICK treatment for hyperkalemia, and dialysis if necessary. Okay, so this is just when the tumor gets killed too quickly. So lung cancer, I just wanted to make this clear again because I think this comes up a lot, is key symptom is a persistent cough. That's one of the first symptoms. Okay, blood problems. So anemia is low red blood cells or low H&H, hemoglobin hematocrit. Signs and symptoms can be palpitations, fatigue, pale, glossitis, so a large swollen tongue, dyspnea, long-term breathing problems can lead to a heart attack if it goes on for a long time. There can be iron deficiency anemia, more common in young adults and women because of menstruation and all of that. Thalassemia is a condition, it's an autosomal recessive condition, produces the inadequate production of hemoglobin, basically. Can be caused by chronic disease, blood loss. It can be acute or chronic. If you lose more than 40% of your blood, it's like a super severe situation. It can be aplastic anemia, so you're not making the red blood cells. Pancytopenia and hypocellular bone marrow would be the causes of that. And then megaloblastic anemia, really, really large red blood cells from lack of like cobalamin, so B12 or folic acid. If it's B12 issue, it's called pernicious anemia. There's no intrinsic factor able to like absorb that B12 into the body. And the main symptom of megaloblastic or pernicious anemia is a beefy tongue, so that beefy, thick, red tongue. The two most common that are talked about, I feel like, on HESIs is that iron deficiency and megaloblastic. So, treatment is to treat the underlying problem. Usually, it's a symptom of something else going on. Maybe give blood products, iron pills, more iron-rich foods. In the corner here, you can see, I feel like they always ask about foods regarding iron. So these are some examples. And then the medication epoetin alpha increases the amount of red blood cells production. But you want to pay attention if they're starting to have chest pain because this medication can also increase blood clots. So if they're having chest pain, you're like, oh, was it a blood clot that became a PE or something like that? So you can also get anemia from red blood cell destruction. So that can be sickle cell. They have abnormally shaped red blood cells. More common in African Americans, it's an autosomal recessive disorder. The hemoglobin is shaped weird, and so it doesn't hold on to oxygen very well. So crises, sickle cell crisis is triggered from situations of low oxygen. So like infection, high altitude, extreme exercise, cold weather, dehydration can trigger that crisis. It can lead to ischemia, infarction, necrosis, and lead to long-term organ involvement. So you want to instruct patients with sickle cell to avoid all of those things if possible. Sickle cell pain is a priority because pain increases oxygen demand and they just simply don't have the ability to replenish their oxygen supply at the time. So if they come in and they have a sickle cell like crisis, obviously they're going to be on oxygen to supplement. We're going to treat their pain, treat whatever cause, like if they're dehydration or electrolyte imbalance and infection. Yeah, they're going to have a PCA pain control so they can feel more in control of their pain. DVT prophylaxis because of that ischemia, necrosis, like the blood is not as oxygenated. Rest and then fluids to keep those kidneys okay. All right. And then we have acquired hemolytic anemia. This comes from physical trauma. So like thrombocytopenia purpura, immune reactions, and infections. So you'll see that purpura, so those purple dots, or the petechiae, which are just smaller purpura. Okay, polycythemia is lots of red blood cells, can lead to hypervolemia, leads to hypertension, gout, stroke, and hyperviscosity. So to treat that, it's phlebotomy, so taking blood out and giving fluids back to try and like dilute it essentially. Hemochromatosis is an autosomal recessive disorder. Increased iron absorption with like causes iron deposits in the body, so it can lead to liver problems, diabetes. You'll have that classic bronze skin, cardiomyopathy, arthritis. The treatment is to remove blood and then give iron chelates, which like make the iron inaccessible to the body, essentially. Okay, so this is just a reminder of how blood products are broken down. So the spleen creates iron, globins, and heme. And then iron gets turned to transferrin and ferritin. Ferritin levels in the body also are measuring iron levels. So if you ever see ferritin or iron, it's measuring the same thing. Globin is the protein aspect, and it's recycled to be amino acids. We're never going to waste proteins unless there's a problem with the kidneys. Heme is converted into bilirubin or albumin. So it becomes, yeah, bilirubin here. It goes to the liver, becomes conjugated bilirubin, urobilinogen, or stercobilin, or whatever. It goes to the feces or the urine to create that yellow or brown color. Okay. So in cases of jaundice, they have too much like blood breakdown and they're just having high amounts of bilirubin floating in the body, which can also create high amounts of ammonia coming from the liver, which can cause problems with brain function. Okay. This is hemochromatosis. The signs and symptoms, you see that bronze look to their skin. And then these are just other signs. Okay, hemostasis. So we have thrombocytopenia, so low amounts of platelets, less than 150,000. They bleed easier, they're not clotting. So if they have this, if you like have to give them an intramuscular injection or do an IV, take an IV out, you're gonna hold pressure for at least 5 minutes. Use like soft bristle toothbrush if they can use toothbrushes. Sometimes it's like contraindicated. They can only use those mouth sponges. Definitely no razors. That's yeah, just a no. They can get hit. So if they're on heparin therapy, yeah. So heparin-induced thrombocytopenia, definitely stop the heparin when platelets fall 50% from baseline or if a thrombus forms. Okay. And they'll usually try and treat that. They'll give like the antidote to heparin. Then there's DIC. We talked about this a little bit. So it's abnormally initiated. So DIC doesn't just like occur on its own. There's usually something underlying that is causing it. So maybe sepsis is causing DIC or it's a part of MODS, you know. Yeah. So we're going to see signs of thrombosis as well as decreased 6Ps like pain, perfusion, or sorry, like, yeah, just the 6Ps you're going to see affected. Hemophilia is X-linked. So it's mom, give it to the son. It can be type A, meaning they're lacking factor 8, or type B, lacking factor 9. And these are factors for clotting. So von Willebrand disease is another type of hemophilia. They're missing the von Willebrand factor. The treatment is to replace the specific clotting factor according to which type of hemophilia it is. You're also going to educate on like when to go to the hospital, like when they're like bleeding too much or, you know, stuff like that. Okay, so that's purpura. This is petechiae, so smaller, and then this is ecchymosis, like a bruise. Problems with hemostasis, we have myelodysplastic syndrome, more common in people over 80 years old. It's a group of disorders from decreased bone marrow function. I haven't really seen that come up a whole bunch, but that's just the definition of it. Neutropenia, we talked about this, low white blood cells. This is an emergency. This is an example of something for neutropenic precautions, like obviously PPE to protect them. We're going to be washing our hands super often, educate about hand hygiene. We're not bringing live fruits or vegetables or plants into the room. If they do eat fruits, like it has to come from a fruit that can be peeled and it's washed first and then peeled outside of the room and then brought in. So there's just lots of specific rules. Usually, like there has to be a really good filter in the room to filter out the air they're getting, stuff like that. Okay. Blood cancers. So we have leukemia. So this affects the blood, bone marrow, lymph, and spleen. It can be acute, so it can be ALL, which is most common in children, AML, which is the most common leukemia in adults. Chronic CML, just remember you're looking for that Philadelphia chromosome, and then CLL. You don't like need to know the crazy specifics of each of the types of leukemia. Just remember like the one, like what it affects, what it decreases, like it decreases the blood products in the body because of bone marrow stuff going on, and then like the main characteristic that I listed here. We have multiple myeloma. This is from the bone marrow. This is cancerous plasma cells entering bone marrow. You're going to see M proteins, Bence-Jones proteins in the urine, if you can remember from patho forever ago. You're going to see symptoms from the bones deteriorating, like hypercalcemia, releasing that calcium into the body, blood, pathological fractures because there's not as much calcium in the bone anymore, and osteoporosis and pain. Lymphoma is a cancer infecting the lymph nodes. There's Hodgkin's. Hodgkin's is predictable. You're going to see Reed-Sternberg cells, fever, night sweats, weight loss, and they're like movable, non-tender nodes. Predictable is what I'm saying is like there's a spread. Like if you look at all the lymph nodes in the body, with Hodgkin's, you're able to predict like, okay, it's going to start in the cervical nodes and move down to the substernal nodes and like where next. They can track it. With non-Hodgkin's, they can't track it. It can jump from cervical down to the lymph nodes in your knee. Like it's not predictable. And then they have painless lymph node enlargement. So, okay. This is just a reminder that stem cell is the basic, like it can become anything type of cell. And then this is how it's just separates. It's just good to know that stem cells and then the blast cells get differentiated to create all these different types of blood cells. Okay, blood therapy, just a good reminder. It needs its own IV site. We're not putting any other medications with it. The only thing that can go with blood is normal saline. You need a large gauge needle, about 18 to 16 gauge. It's a high alert medication, so second nurse needs to verify. Doctor, before you even start getting the blood out, it needs to have the consent form filled out and then the blood type matched. And then just remember that 1 unit of packed red blood cells raises hematocrit by 3%, but it often takes a couple days to see that increase. If there is a transfusion reaction, first action is to stop the transfusion, take the tubing out and like take the blood in the tubing, put new tubing in with this normal saline and attach it to the IV and keep that normal saline running. You're going to keep the bag and the tubing and send it to the blood bank so they can analyze it. Obviously, like you're going to do that after you're staying with the patient because now they're unstable, you've called for help, you're getting their vital signs, a urine sample, making sure they're having output, that their kidneys aren't being affected, treat their symptoms, stuff like that, get a blood sample. Symptoms could be like a fever, mild allergic reactions. You don't necessarily have to stop it, follow protocol. Sometimes you can just call and get some Benadryl if they're just itchy, or a steroid. Epinephrine would be if they're having an anaphylactic reaction to the blood. Let's see, circulatory overload, like they're just like they have too much fluid. You want to sit them upright so they can breathe. Get them an x-ray to see if it's infiltrated their lungs. Give them a diuretic, morphine, because it enlarges the vessels and makes it easier to breathe. See sepsis, get a culture and antibiotics. One common side effect of a hemolytic reaction is back pain. So those are just things to be aware of. Just remember, these are all the types of compatibility. O negative is the universal donor. AB positive is the universal recipient. Okay. Immune response, it can be local. So we can see redness, hot, pain, swelling, loss of function. So like decrease, so like let's say they have like a wound that's healing, so a little bit of redness, a little bit of pain, a little bit of swelling, totally normal in the healing process. However, if it's very painful, very red, very hot to the touch, that's the difference, and that's how you know we have like an infection brewing. Systemic response would be a fever, shift to the left, meaning there's a high amount of immature neutrophils. And remember, neutrophils are those first responders, is about like 50 to 70% of them in a test of our white blood cells. Nausea, vomiting, or vital signs changes are also systemic. As far as treating a fever, if they're not immunocompromised or they're not like a pregnant female or someone, a child with like febrile seizures, we don't necessarily need to treat a fever if they're not having any side effects, because a fever creates a hostile environment for pathogens. However, if they are experiencing side effects, don't hesitate to treat a fever. Okay. Remember that elderly people may have a blunted febrile effect, so fever is not the greatest indicator for infection as much as like law or level of consciousness, like confusion. because a lot of elderly people take NSAIDs or Tylenol on a daily basis, and it's going to blunt that fever. So you're not going to notice that they have a fever because that medication's working in their body. Okay. An acquired immune response. So it can be active acquired, so like vaccines, or it can be passive, getting it like getting the antibody through breast milk. Active is meaning like your body gets the virus, an inactivated form of the virus, and it actually has to build its own antibodies to that exposure. Whereas passive, you just get the antibodies. Okay. And innate, you just are born with it. Humoral, it's antibodies, so B cells, memory cells. And then cell mediated T cells can be the natural cells, natural killer cells, or, those things. Okay, hypersensitivity reactions. So this is a good review from second semester, but we have type 1. You're going to see a lot of IgE immunoglobulins. It can be anaphylactic response or an atopic, so like a topical response. Type 2, you're going to see tissue damage, could be from ABO, so blood product incompatibility, or hemolytic anemia. Type 3 is an autoimmune response like lupus or rheumatoid arthritis. Type 4 is delayed, so it's like contact dermatitis, for example, like coming in contact with poison ivy for the first time doesn't do anything, but the second time you come in contact with it, it's going to cause a reaction. Could be drug reactions or transplant rejection. So immunotherapy can help decrease an allergen. It stimulates IgG to bind with allergen and decrease the reaction to stop the release of histamine. It can be risky because there's a high risk of anaphylaxis, so you have to stay with this patient, high alert. Sneezing, interestingly enough, can indicate an impending reaction because that histamine is starting to irritate the glands and stuff around here. Okay. Latex allergies can be a type 1 hypersensitivity or a type 4. Okay. And if you have a latex allergy, it's very common that you'll have an other food allergy, like bananas is a common one, avocado, apples, and then all the ones listed down here. Okay. So always check the things in the hospital that you're using with a latex allergy patient to make sure it doesn't have latex. Many hospitals are moving away from having anything with latex, but you never know. So. Okay, HLA, human leukocyte antigens. We all have them. We all have a specific set of them. There's 6. All 6 need to match before a transplant. A positive cross match sounds like it would be a good thing, but it's not. It means you cannot go through with this transplant or a reaction will occur. Basically, it was matched and it shows that these 6 antigens don't match the transplant antigens and there will be a reaction. There will be a positive adverse reaction. Okay, hyperacute rejection happens within 24 hours. You must remove the organ with hyperacute. If it's an acute, it occurs within the first 6 months, and the treatment is to increase immunosuppressants. Chronic rejection is irreversible. It's going to result in organ failure, and eventually they'll just need to be taken out. Okay, remember they're going to be immunosuppressed, so they're going to not get like those live vaccines. They might need prophylactic antibiotic therapy, staying away from large crowds, respiratory illnesses, all that stuff. Okay, so graft versus host disease. This is when the graft's immune cells recognize the host as foreign, so the graft actually starts to attack the body instead of our body receiving the organ attacking the organ. Okay. Okay, practice questions. This is normal, pause, and we'll move and talk about it. Okay, so patient whose cancer is about to begin chemo. They ask why 2 chemotherapeutic agents are being used instead of 1. Why? What did the nurse say? B, 2 agents used together can have synergistic effects. And remember, synergy means the 2 drugs will create an amplified effect, like the expected results. And so combination therapy allows the cell to kill all phases of the cell cycle. Okay. Okay, so this is talking about who should not be assigned to care for someone who has radiation. So B, the answer is nursing assistant who's pregnant. Remember, pregnancies, they're very susceptible to radiation, the fetus, and fetus can be affected. So 6 months postpartum won't be affected as much. RN is allergic to iodine. Okay, and then just don't use iodine, RN with a 3-year-old at home. Again, you're not taking this radiation home, but the person who's pregnant has another living thing inside of them that could be affected. So, okay. Okay, signs and symptoms of bleeding from someone with acute leukemia. What is the best site for examining the presence of petechiae? So African American client, they're darker skinned. You're not going to be able to see purpura, petechiae on like their normal trunk that you would on a lighter skinned person. So you're going to want to look on like the hands, the soles of the feet, which is D, or the mouth, or like, buttocks even. So, okay. Okay, so being treated for advanced breast cancer with chemo states that she must be allergic to one of her drugs because her entire face is swollen. What assessment did they perform? A, ask whether the client has other known allergies. Maybe, but like what she's reporting to you should set off a red flag in your head based off of something that we learned about as a complication to chemo. So let's keep going. Checks cap refill on fingernails bilaterally. Might be good, but her face is swollen. We're not really concerned about the perfusion to her hands quite yet. C, examines the client's neck and chest for edema and engorged veins. So this should, again, trigger you in your brain to think superior vena cava syndrome. So that facial swelling, periorbital edema, JVD swelling, puffiness, that can all be from that vena cava syndrome, which is an oncological emergency. So that further assessment confirms whether or not she has that issue. Okay. And then blood pressure in right arm versus left arm, again, C more accurately assesses the problem that this patient is stating. Okay, so they're getting epoetin alpha or Procrit. What are the following indicates that the dose should be held in the healthcare notified? So hematocrit at 28%, probably they still need their epoetin alpha. That's a little low. Total white blood cell count is 6,200. It's pretty normal. Remember, it's between 5 and 10,000. Blood pressure changes from 130/90 to 148/98. We'll talk about why that's the answer in just a sec, but then temp change from 99 to 100. So that wouldn't necessarily indicate you need to hold epoetin alpha. You might need to do another action because they're heading towards like neutropenic fever, but that's not necessarily about Procrit, the drug. Okay, so remember Procrit, epoetin alpha, it increases the amount of blood products that are made. That can also increase your risk for thrombus formation, like clots, high blood pressure, intracranial swelling, stuff like that. So if their blood pressure, they're getting hypertensive, it's causing their heart some kind of problem. And we're going to be a little wary, well, very wary of giving that Procrit and talk to the provider before we give it. Okay. Okay, lowest level of bone marrow activity in neutropenia is at the nadir. That's the lowest level of like the curve that they show you in class. Okay. Okay, so DIC, what's most helpful in preventing this? A, monitoring platelets. Yeah, it's great to monitor platelets, but what are you doing to prevent DIC? You're just going to catch DIC. You're not actually intervening anywhere. That's an assessment. Okay. B, administering packed red blood cells. It's not necessarily like gonna help prevent DIC by just giving them blood products they don't need, right? C, using strict aseptic technique to prevent infection. So going back to sepsis, sepsis is sort of the answer for a lot of things. Sepsis is the number one cause, well, maybe not number one, but is a very, very high leading cause of DIC because it's related to MODS. And so if we prevent sepsis, then we prevent DIC in theory. And then D, administering low dose heparin therapy for clients on bed rest. I mean, you are going to be doing that, but that's not as good as a way to prevent DIC as C. So, because it, yeah. Okay. Suspect cancer recalls that the only diagnostic procedure that is definitive for diagnosis of cancer is biopsy. That's the gold standard. Okay, oncologist said the patient, he has a benign tumor in the liver. Patient asks, what's the main difference between benign and malignant tumors? The nurse answers, C, benign tumors do not invade and spread to other organs. One, malignant tumors usually are encapsulated. No, that's benign tumors. Malignant tumors do not have a rare recurrence rate. They actually have a pretty common recurrence rate. And then malignant tumors require less nutrients for their cells than benign tumors. They need more nutrients because they're constantly growing. Okay, a nurse determines the client's having a transfusion reaction. The nurse stops the transfusion. What should they do next? The answer is C, run same saline at a keep vein open rate, which is about 50, 75. Okay. And we're not removing the IV line because we still got to give them fluids. 5% dextrose and water. Nope, we're doing normal saline. Obtain a culture of the tip of the catheter removed from the client. You will do this. Like, I guess these are things you could do later on down the line, but this is saying what's happening next. Like, you're going to run normal saline next. You will obtain a culture of the tip and stop and send the bag off for testing and stuff like that, but not in the immediate, like right after you stop the transfusion. Okay. Getting a transfusion of platelets. Nurse evaluates that the client is benefiting most if they exhibit which finding. So, decreased oozing of blood from puncture sites and gums, because platelets are in charge of clotting, and if they're not oozing blood anymore, then they're clotting, right? So, the effect of a transfusion of platelets would be that. Okay. Okay, they get an infusion of packed red blood cells, but they have now tachycardia, bounding pulses, crackles, and wheezes. What should they do first? First thing you're going to do is to place the client in a high Fowler position because they're now experiencing fluid overload. Okay. Legs elevated is only going to increase the return of blood and fluid to the lungs, making all of these problems worse. You're not going to increase the rate of infusion because they are overloaded. And then consult with healthcare provider regarding initiation of oxygen therapy. Yeah, that could be something, but first, the easiest thing to do is just sit them up. Okay. Okay, they're admitting a 24-year-old African American. I think I put American. That's funny. They're real American. Anyways, they have a history of gastric bypass surgery. Okay. The thing with gastric bypass surgery or any surgery regarding the GI system, it can cause a decrease of intrinsic factor, which is found in the GI system, and you need intrinsic factor in order to absorb B12 into the body. And so it can cause a vitamin B12 deficiency. Okay. And that's like your key for knowing which type of iron or like which type of blood deficiency there is, anemia. Okay. Okay, folic acid deficiency. The most common deficiency for alcoholics is folic acid. 80% of them have it. So, hey, Alcoholics Anonymous would be a good referral for someone with folic acid deficiency. Okay. They have anemia, begins to complain of dyspnea when ambulating. What should they do first? B is get a wheelchair for the client. The first thing you do is like the safest thing is stop activity. If they're falling, lower them to the floor, get a chair, help them sit down. You don't want to exert them even more by like, all right, let's walk back to bed. Like you want them to sit as soon as possible. Okay. And the rest of these things, D is like contraindicated. You don't want to do that. And then C and A would be good things to do once you've got them sitting and back in bed. All right. When caring for someone with thrombocytopenia, the nurse should C, avoid invasive procedures. If you don't have to give them an intramuscular shot, you're not going to. So A, discourage the use of stool softeners. No, you actually want to encourage this to prevent straining and like hemorrhoids and bleeding from the rectum. Assess temperature reading every 6 hours. Not necessary because thrombocytopenia means platelets, not white blood cells. D, encourage the use of a hard brittle toothbrush. No, you want a soft toothbrush, if any toothbrush at all. Okay. And that is it. Sorry, that was another long one, but we reviewed blood, and then also went over the new topic of cancer. So hope that helps.